Good afternoon to all. It's of course a pleasure to be here in this course with you, and thank you to SciOP for including this topic in the course and for inviting me to speak. So I have nothing to disclose, and I'd like to start with a question. Why talk about palliative care in oncology? Well, because cancer happens to people. And it's really easy in our daily life amongst everything to forget this basic fact that in our case, we're dealing with children, young people and their families on a daily basis. So we are going through this lecture to look at things from a slightly different view from what you've been learning so far. So I hope you bear with me after lunch on a Saturday afternoon. And for those of you who have never had a chance to learn about palliative care, I would like to emphasize that it is about so much more than terminal illnesses and that in fact, it's increasingly being recognized as a way to improve the lives of people who are affected with life-limiting or life-threatening diseases like cancer. So in oncology, we are familiar with all the possible outcomes of our patients. But from the outset, what we cannot really tell most times is which one of our 5 new patients will ultimately die from the disease. And this makes it really important to treat everyone the same and to pay attention to so many different details from the beginning to all of our patients. So we do know a lot about most of the diseases, but unless we've been there ourselves or our family, we don't really know much about the whole disease experience. And for ayahs with cancer, this means that they will have unique characteristics and needs that you've been discussing in the past day. And this must be met through a team of doctors and therapists and even body image advisors, and including supportive and palliative care specialists, as was recommended by ESMO and SciOP very recently. So what have ayahs with cancer told us that we can use to really try to improve the care that we deliver to them? Well, before continuing, I have to declare that really most of the evidence that we have about these themes does come from countries outside of Europe and which are developed countries. And also, we cannot look at Europe as a whole because there are differences that we must recognize that will have an impact on the way that care is delivered. And so this lecture should not be taken as a strict guide, but rather as an eye-opening guide to really help you in your daily life from today on. So young people with cancer. A diagnosis of cancer in the teenage years or in young adulthood will really stunt a lot of normal life transitions, and they will be forced to live with a high degree of uncertainty. So when we see an ayah in our wards, it's very easy for us to see all the physical symptoms, either disease or treatment related. But what we often don't see is all the psychological and spiritual symptoms that they are so very good at hiding from us. And I have to make a parenthesis here now to talk a little bit about patient-reported outcome measures. These are tools that can be available either on paper or through digital means, either in hospital or even at home. And these are really being increasingly used as a way to detect and to measure all symptoms, not just physical ones, and not just in the daily clinical care, but also in research. And here in Europe, it was just finished a project by the European Commission called MyPol, which is about using a digital app to measure patient-reported outcome measures in adolescents, adults, and children with cancer. We don't know yet much about it because it hasn't been published, the results, but we do know that the pilots that were done in 5 different European countries studies seem to have had good results. So we're looking forward to see this project come to life and to a wide use. And it must be something like this. This is an example from a similar app that is used in the United States. And you can from this app, you can select all the different symptoms that you can be going through. And it's not just nausea caused by chemotherapy, but it's also worrying, lack of appetite, sleep disturbances, and then you can tell how the symptom is affecting you and how do you think it's related to what's happening to you, either treatment or disease related. And amongst these hidden symptoms, I think fear is really the one that they really, it's really at the base of everything. Fear about the future, about what's to become and what's to happen to them. And at the end of life, what will come more to the surface is really anxiety and depression. But yet, these are still very often under-recognized and under-treated by us oncologists. So how do IAs with cancer deal with stressors? They usually tend to deal in very, I would say, positive ways, engaging with family and friends and even romantic relationships. They will do it in person. They will do it, of course, through technology, because it really goes very well with this age group. Yet some will engage in a behavior with their families that is about hiding. It's something called mutual pretense or conspiracy of silence. You can choose what to call it, but it really is about not talking about bad things. So because if we don't talk about these, they are not going to happen. So we have an elephant in the room, an elephant that is so big that you cannot ignore it, but yet everyone is, looking to the other side, trying to protect the others from it. But this is nothing, no protective behavior. So all this suffering really leads to a process which is called total pain. So it's a pain that really is beyond just the physical pain. And so much so that at the end of life, it may even be refractory to high doses of strong opioids. And also for survivors, it does take a toll on them. And the post-traumatic stress disorder that survivors endure may really negatively affect their future life. So this total pain does require a total approach. And I just want to stress, because we don't have time here to go through details, that approaching chronic pain really requires a multimodal approach. And it's not just about using drugs or integrative techniques. It's really using psychological techniques as well, and normalizing life as much as possible. So I refer you to these two documents, this paper by Friedrichsdorf and Postier, and this document by the WHO that is specific for cancer pain in adolescents and adults. And you can easily find it on WHO's website. So what can we oncologists do to deal with this total pain? How can we totally approach it? So I think that the key is really to understand what IAs with cancer want and what they need. And what they need and what they tell us is that they want to be cared for with love, respect, and privacy, that they want to keep their independence as much as possible, and that they want to develop relationships that facilitate the expression of emotions. Now, when it comes to care and decision-making, that may vary, because some of them will really want to become involved in decision-making, and others will just want to be informed about it and not really be an active part. And it's really important also to understand that even for a given person, this process of decision-making is not static in time. It will evolve. It will evolve with the disease experience, but it will also change according to the type of decision that is to be made, if it's a minor or a major decision. So it's really not a linear, static process, rather a dynamic one. And it's also important to understand that this is an important issue for IAS, the decision making, because they not only want to be informed and sometimes involved, but they also experience something which is called decisional regret. And this seems to be less common when they really are able to develop a trusting, caring relationship with their oncologist. So we are really key here to help them achieve better outcomes. And the way to improve this communication between oncologists and IAS is through a process called advanced care planning. And this is a tool that we can use to evaluate and discuss goals and preferences of future healthcare. It is something that should be done while the disease is stable, not at times of crisis, but then when crises arise, and these will come in cancer care, then we can revisit what we have discussed and what we have hopefully written down, and we can work around those wishes and preferences. So what do IAS with cancer consider when thinking about their future? So they do think about themselves, but very important, they also think about their family and what their decisions will mean for their family. So this is why we have to really consider that the unit of our care is the AYA and their family. We really have to encourage the conversation amongst them, and really advanced care planning is a useful tool for that. But this is a process that is not to be done lightly. It does require some training, it does require time, and it does require us also to evaluate if the AYA and the family are ready for that. And I bring you here 3 questions that our colleagues in the United States have suggested as useful to evaluate that readiness for engaging in advanced care planning. And also, this is not something that is to be carved in stone. It's something that really needs to be revisited whenever circumstances change. And it is to be shared with all of us involved. And this is a process that is really not helpful for IAS and parents. It's also helpful for us doctors, because it will help us to facilitate communication with patient and family, and also to support the decision-making process. So this is really something helpful for all the stakeholders involved, not just for IAS and their parents. And I bring you here some examples, again, from the United States, an example from the Boston Children's Hospital, and the document that is most used in the United States, which is Voicing My Choices. As you can see, it is specifically designed for adolescents and young adults. And some young adults will also use the 5 wishes, which is an adult-focused document, but it is widely spread in the United States. And interestingly, the most helpful item of these 5 wishes is what I want my loved ones to know. And the most stressful is the kind of medical treatment I want or don't want to go through. But here in Europe, we also have some examples. And our friends in the Netherlands have a whole page dedicated to advanced care planning in children and teenagers, with materials also for clinicians and for parents. In the UK, there's also a dedicated web page with several models for advanced care plan, but these plans are mostly focused on end-of-life care and not from diagnosis onwards. Still in Europe, in Belgium, a 5-year project about advanced care plan in teenagers with cancer using conversation cards. It was just finished, so it's not yet fully analyzed, but some interim presentations have shown it to be feasible and well accepted by teenagers with cancer in Europe. So when we come to end of life, which is defined as the last 12 months of life, we know that the care of IAS with cancer will be centered around active medical management, and it will mostly happen in the hospital and represent very high intensity of care. And I would like to remind you that really anxiety is amongst the most prevalent symptoms, and that it is most prevalent in older ayahs, and that we do tend to under-recognize it. The majority of ayahs with cancer do seem to prefer to die at home, and in some studies done in the US, this preference may be as high as 90%. Yet they are likely to die in hospital, and some of them in the ICU after some aggressive measures of resuscitation. A recent study done in Canada has indeed shown that adolescents, ayahs with cancer, do experience a high level of intensity of care at the end of life at a percentage that is higher than that experienced in the same region by children or by older adults. And the risk of that is higher in the younger ayahs from 15 to 19 years of age, and in those with hematological conditions. So what can we do to change this scenario for end-of-life ayahs with cancer? Well, we can bring to it a patient-centered approach through palliative care. And we really must work to understand their preferences, their goals, and then really try to honor their wishes. Again, in the United States, randomized controlled trial at the end of life showed that by engaging in advanced care planning, it was really possible to change the scenario of end-of-life care for ayahs with cancer, and that it did enable families to understand and to honor the adolescents' wishes at the end of life. But how do you make decisions at the end of life? We do it differently, it seems, because while doctors are mostly influenced by patients and family preferences, for ayahs, what is most important is their relationship with the significant others, when we spoke about this before, and for parents is deciding as my child prefers. And while recognizing that these end-of-life conversations are very difficult for all involved, including us, oncologists, they have to be had. Because if we don't have these end-of-life conversations, then it's just not about having an elephant in the room. There will be some demons that will come into the room also, and the family will have to live with this long after the ayah is gone. So we really must work through these difficult end-of-life conversations and learn how to do it. Because if we don't ask, we don't know. And when we ask ayahs what they want, at least in the US, they are really open to early conversations about end-of-life preferences. And we understand that spirituality is important to them, and they really mostly value honest conversations. And this is a process important not just for us oncologists, but also for the families, because they also tend to hide their feelings and remember the mutual pretense. Let's not talk about bad things. In the US, the National Cancer Institute has a wonderful page that I invite you to explore about helping young people face end-of-life care decisions. So they do give a lot of what I think is very useful advice for young people with cancer facing end-of-life care decisions. And again, they do stress on this page that it seems to be very helpful to address these questions early on the disease course, because that will take a lot of the stress from living with this process. So because of all this planning and all these additional layers of support, ayahs with cancer who are referred to palliative care do seem to have better outcomes at the end of life, with less aggressive care, more in line with their preferences. And a recent study in the US also showed that teenagers with cancer referred to a palliative care service really do appreciate the level of support that they get from other patients and from the volunteers. And I would also like to call your attention to a process which is called dignity therapy. And this involves helping someone who is dying to prepare a legacy, and it can take several forms, as you can see on this slide. But I was saying to prepare a legacy that will represent who they are and what their life is about. And this will really endure after they are gone and will help their families through the grieving process. This dignity therapy, it did start with adults, but in recent years, it has been used with adolescents and even with children too. So coming to an end, what I want to stress is that really building a relationship with IS with cancer, it must be based on trust, honesty, and mutual understanding. And as a few take-home messages, most of all, we should not assume that we know what Aya are going through or what Aya want. We do have to ask. And the first things we learn when training about communication is to use open-ended questions and also to return a difficult question with another question. So if you are asked something that you really don't wish to answer, or you don't want to be so honest and so brute, you should return with another question. Why are you asking that? Or what do you think about that? So we can use this tool to help us go through these different conversations. So by treating the young person with cancer as an equal and really helping them make their own decisions, we will help them achieve their independence, self-confidence, and sense of self that ultimately are keys for better outcomes wherever the disease takes them, hopefully to survivorship. So I think it's really time for pediatric oncology to embrace pediatric palliative care and all the additional layers that it does bring to the daily care of young people with cancer. And because while palliative care may not be the latest or most innovative drug on the market, it certainly is one that does change the lives of those that receive it, and with very few, if any, side effects. So I would like to thank you for your attention. Please do explore our group's page on SIOP's website. And I'm here if you want to ask something. Thank you.